Yeah.
Okay.
Good afternoon, everybody, or good morning, or good evening, depending on where you are in the world today. I'm Barbara Stillwell. I'm based in the UK, so for me it's afternoon, tea time, in fact, because we're in England, and that's what we have to do. My colleagues are all in Canada this afternoon. I'm going to introduce them to you in just a moment, but first I want to welcome all of you to this webinar held in troubled times for all of us, in difficult times. And we hope that what we're going to be able to do is to share with you some positive experiences, some encouragement, some leadership in this difficult time, so that you will be inspired as well, as my colleagues in Canada are, and I'm seeing that on a daily basis, to share our expertise, to share our knowledge, and to step forward, which I know nurses around the world are doing at the moment, stepping forward to care for patients in times that are positively dangerous for many of us. So much respect to all of you who are listening, and I hope very much that you will be inspired by this webinar, by my colleagues, and that you will contribute. You will ask questions, you will share your experiences, you'll let us get to know what you're doing. So I'm going to introduce Doris, Susan, and Heather, who are all from the Registered Nurses Association of Ontario. If you have previously met Doris, you will certainly remember her. Doris, I have actually never met Doris. I've only ever met her on webinars and online, and I feel already she is my sister, certainly my soul sister.
Yes.
We're both nurses, we're both no longer in the first flush of youth, in the second flush of youth, and bringing, I think, our experience to leadership positions, about which both of us feel, I think, very strongly. And Doris is a mentor, a living legend, I think I would say. Doris, it's such a pleasure to be able to introduce you. She's also taught me one very important thing this week. She's taught me you can make a lot of noise for nurses with a lid and a spoon. So I encourage you to get your lids and spoons, because we're going to be having some fun later on and showing our respect for people who are out there. So Doris, please let me introduce you. Let me just say one thing. If you're going to ask a question, can you put it in the Q&A boxes, which you'll see at the bottom of your screen on the Zoom screen, and I will be monitoring them and sharing them as we go through. So please do that. Doris, over to you.
Thank you so very much. And before I move any further, let me say this. There is no living legend without partners. And I have been blessed in previous roles and in my role at RNAO for the past 20-something years, since 1996 at the helm of RNAO, to be blessed with boards of directors that say to me, run faster, go get it, go higher, improve the world. So that has been first and foremost a blessing, because if not, I would not have stayed that long. Second, and equally important, living legends need teams. And I want with that not to take time to introduce the 120 people that work at RNAO full time, passionately, as passionately you see me and people describe me, but two of them, Heather McConnell, who is Associate Director, Guideline Implementation and Knowledge Transfer at RNAO, and who has now taken a critical role in leading all the activities that we are doing with aged homes or nursing homes or retirement homes, or those that live in congregate situations that are older and that in all the countries of the world during COVID have seen difficult times. I also want to introduce Susan McNeill, Senior Program Manager, Implementation Science, and she says also social movement knowledge action, which is critically important, and you will see that. And Susan has taken the important role of really rallying up the troops on all the aspects that have to do not only with celebrating the contribution of nurses, which in itself is critical at the time that you need energy, also with the Ontario Health Teams, which are a new structure in Ontario, which was put to test during COVID before anybody could even think about evaluation, and she has kept them going in a marvelous way. So this is why we called what we do Together We Can Do It, because I want to thank you, Barbara, to you and Hannah, and of course PG, my right hand at RNAO, that keeps everything going, and also the partnership with Nursing Now. It is in times of serious crisis that I think Nursing Now takes even a more important role and in shining the light on the contribution of nurses. I don't need to tell you that this is the year of the nurse and the midwife. 2020 is the year of the nurse and the midwife. It is when the World Health Organization decided to call it the year of the nurse and the midwife, and it connected with Nursing Now and with the International Council of Nurses, ICN, to what we thought would be a year of celebrations and contributions. Well, as terrible as it sounds with COVID-19 for everybody around the world, those that are a bit after the curve and those that are in the peak of the curve like us in Canada, or those that are coming behind and will see the difficult times that will come ahead. In a sense, actually, COVID-19 gave us in a silver plate, I think, the year of the nurse. One of my colleagues, Dr. Irma-Jean Beinok, with whom I wrote the book that actually is now holding here my computer, this book, the Transforming Nursing Through Knowledge. I did a tweet that stuck with me that is very, very apropos. She said, and she goes every day, by the way, doing this, and many of us do. And she said, look, this is the year of the nurse. And look what nurses did. Nurses transform it in the year of the patient. And it's so true, colleagues. Nurses, as always we do, we put patients first in everything we do. We do that with knowledge, we do that with compassion, and we do that with unimaginable courage. And we will talk about the courage during today's presentation and the knowledge and the compassion, because when you think about PPEs and the shortage of PPEs, my golly, that requires courage to be on the front lines of care. And it's to those people in the front lines of care and all the rest of us that are there to support you that really we dedicate this Nursing Now global presentation on what is it that nursing is doing collectively for the world and how we will keep going forward and ensuring that no one forgets what we are doing during COVID. So let us tell you a bit about RNAO, how we are shaping and reshaping the pandemic response, like any social movement does, protecting the public and supporting nurses and other health providers. And yes, when we speak about all health providers. The leadership role that we have played with government and the media, and I know some of my colleagues that work in our communications department are listening, so thanks to all of you as well. They have been critical. Policy analysis and recommendations with our policy department, and our colleague, Matt Calway, who actually was seconded to look after a new program that we will speak on, the persons that experience homelessness, and health human resource program that we have through Via Nurse, and how do we go about protecting the most vulnerable, which sometimes we will see all the curves that people are showing and all the projections of government, and sometimes, if not many, those vulnerable populations are forgotten. Well, not for nurses, colleagues. We know that you, in any country that you're joining, as well as us here in Canada, do not forget ever vulnerable populations. So we will speak about Together We Can Do It and cheering up health workers, and you will have a chance to practice it, and we will engage in dialogue on how to be involved and keep up to date in the go forward. If at any point during the presentation you have questions, you simply go with your hand, and then Barbara still will actually stop us and answer to your questions, because this is about you. Who are we? So we are the professional association representing registered nurses, nurse practitioners, and nursing students in Ontario, Canada. Ontario is the largest jurisdiction in Canada. It accounts for about a third of the population. We are the strong, credible voice leading the nursing profession to influence and promote healthy public policy and clinical excellence. We are well known for two critical pillars. One is the best practice guidelines that are being used all over the world in about 1,000 organizations in close to 20 countries. And the health policy program, which really leads not only during COVID, but actually every single day in our life at RNAO. Next one, please. So this is the best practice guidelines. As you can see, this is where we are in all the continents. We have host organizations in 15 countries that run the program for their country. One example is the program in Spain run by Dr. Teresa Moreno at the federal government, with many best practice spotlights all over Spain. The program in Chile run by the government of Chile for the public hospitals and by Amalia Silva for the universities, and so forth in the different countries. I don't know if our colleagues from Australia, but AMNF in South Australia, in Adelaide, runs the program in Australia, and so forth in Italy, and as I said, close to 20 countries around the world. I hope some of our colleagues in Jamaica are present. All of you doing tremendous work on advancing evidence-based practice for the people that we serve. So let's talk about RNAO and COVID during these last several months. First of all, the leadership role with government. Let me tell you, there is not one area that is being tackled that RNAO has not had either the fingers in the pulse responding or the fingers in the pulse mobilizing to action at the policy level in government. We participate in all the government activities. We are connected directly with the command table, connected with the Ontario Medical Chief Officer of Health, connected with Health Canada. We are part of the Emergency Operations Center, participating at 9 a.m. in daily calls. Those were initiated very early on. And yes, RNAO requested that those be initiated early on as a result of the learnings from SARS, when we did not have the same structure, both in government or the attention that RNAO at the time was deserving. One of the aspects that happened following SARS is that RNAO actually demanded a full public inquiry, and that did take place. And many learnings, like the communication, like the engaging with associations, the issues of proactively looking at the precautionary principle. All those aspects actually resulted from the SARS inquiry. We are members of the collaboration table of key stakeholders with governments and members of the government media table where our Director of Communications, Marianne Sich, participates. Next one, please. Evidence-based policy is what guides us always. So we will never say, for example, things like in nursing homes, we cannot have PPEs now because we don't have enough. We will say nursing homes require universal masking, and the fact that we don't have them only propels action to ensure that we will have that. And you will hear more about that. We have had 17 urgent recommendations, and you can review them on rnao.ca or in the blog that I write daily. Next one, please, Susan. Impacting of advocacy efforts, either fully or partially, the following have been adopted by government, pushed significantly by RNAO. Universal masking for all staff facing patients, although we requested that actually this be implemented first in nursing homes, and the reason being that those were the most vulnerable population and a population that even if they get access to a ventilator, they likely will not survive. So we did ask for universal asking for staff working in nursing homes very early on. The first uptake actually, much like in other countries, was hospital care. The exception likely is Islas Baleares, where the entire approach, and I will speak about that, has been primary care and home care. In the rest of the world, most of the countries have approached this as hospital care mainly. And I think actually that will prove to be a shortfall. Pre-outbreak testing and surveillance is something that to this day we are forcing, pushing. I know that today the discussion was going to happen at the command center once again on the urge of RNAO for pre-outbreak testing for not only clinical work, but surveillance. In the last directive that came yesterday from government late at night, it did say that pre-outbreak surveillance will start to occur. To me, it's like PPEs. It starts to occur when it's happening. Before that is, good progress, but it's not signed on the dot line, it's not happening. So PPEs coming, pre-outbreak surveillance coming. For RNAO, that is insufficient, is inadequate, and it lets both workers and also populations down. So we are going to be applauding when we see pre-outbreak surveillance happening, the testing, and happening in nursing homes, happening in shelters, happening in correctional facilities, happening in supportive housing, happening in any other group, congregate people with disabilities, for example, and also happening in our indigenous communities. When you do the pre-outbreak surveillance, you're not walking on the blind anymore. You know where you're walking. You know what are your hotspots to be attentive to. And you also then can do case and contact tracing much, much more robustly, and therefore suffocate COVID-19, so to speak, rather than COVID-19 suffocating all of us with the stress and with the death toll that we are seeing, for example, in nursing homes. Self-isolation of suspected persons and confirmed persons. I have a big problem calling it cases, but I know in population health we call it cases. For me, every case, and for us at RNAO, every case is a person with a story with them, and every person deserves, the important calling of such. Workers should work in only one facility. We have asked that for a long time. It has been instituted now in long-term care that you can only work in one facility. The reason we call it full-time is because you do not want to end up in a situation where those workers actually cannot make means end. And the reality is that at least in Ontario, about 45 to 50% of the personal support workers work in multiple employers, 2 or 3 facilities. So it is a must that we up the game to full-time. In BC, British Columbia, the government was much early on responding to this aspect of both testing more and also the issue of working in only one facility. And the results show themselves because their number of death toll. And I don't just measure the number of cases, because cases, it depends who you measure and who you really then report on. So the number of case toll is actually lower in BC significantly. Media has been constant. I call it the
Doris.
Yes.
Doris, we've got one question just before you move to the media.
Yes.
The question is, does or should the LTC recommendations apply to retirement homes too?
Yes. Yes, very good question. Thank you. All the recommendations that the government, all the recommendations we make relate actually to retirement homes. It also relates to shelters. It also relates to persons that live in indigenous communities, our sisters and brothers there. It relates to other confined settings like correction facilities. So absolutely yes. All the directives that government has written for retirement homes apply also to, for long-term care homes, apply also to retirement homes. So when the government puts in Ontario a recommendation for nursing homes that are part of long-term care, those apply also, Barbara, thank you for the question, to retirement homes. I hope.
Fantastic. Thank you, Doris.
Yes. And media, I call it tongue-in-cheek and really with huge respect, the insatiable media, because it seems that they're constantly calling us. And RNAO has been 156 times since, as of April 21, so meaning for a matter of a month. So just picture what that means on a daily basis for us that speak with the media, whether it's television, whether it's radio, whether it is print media, absolutely all the time. There is a big difference, and I have said this to the media, there is a big difference between my experience during SARS with the media and my experience now. I find that during SARS, the media was more sensationalist. It was more about what's the punchline to kind of blame government and the world and etc. The media this time has been so tremendously respectful and so tremendously factual. It has played an absolutely key role in keeping people well informed and yet pushing the issues that need to be pushed, such as the devastating situation in Ontario, in nursing homes, and also in Quebec, another jurisdiction of Canada, of nursing homes. So the media has played a critical role keeping the public informed and in fact helping in pushing critical policy issues. These are examples that my colleague Susan put in the slide, and these are examples, and really it has been national newspapers that we have been quoted constantly, national media, and then of course in Ontario also, but also global and quite frankly international, because we have been many times interviewed by Reuters.
Doris, we have another question about the media.
Yes.
So will you allow your nurses also to speak to the media? And I guess that means nurses who are in practice.
Yes,
are they allowed to speak?
This is a tremendous question, Susan. If you can put the previous slide, please. It's such an important question. And I only can speak for not only Ontario, but Canada. The difference, let me speak first of this. The difference between physicians and nurses in Canada in terms of employment status is that nurses, 90% of them, if not 95% of them, are employed by an organization. Physicians, on the other hand, are not considered staff. So it's very different, like for example, in Europe, right, where physicians are employed by an organization. They're employed by the hospital. They're employed by the nursing home. In Canada, physicians are considered self-employed and they work for an organization. So that's why they need what's called the Medical Advisory Committee to approve their employment in that facility. Therefore, physicians, for the most, are much, much freer without needing to ask permission from their organizations to speak with the media. This is a huge, huge handcuff that we as nurses have. I am not suggesting, though, Barbara, as some do, that nurses should all work in private practice independently and be contracted by an employer. I am not. What I am pleading to employers, all of them, whether it's hospitals, whether it's nursing homes, whether it is correctional facilities, home care, you name it, all of it, is please allow frontline nurses and other health professionals to speak out. Allow them when things are going well at the very least. Even that is a stumbling block, Barbara. And in my view, it shows courage for an organization if you also allow them to speak when things are not well. So it's very difficult because we have contacted nurses and they're not allowed to speak with the media. It is a big, big problem because, in fact, I don't want to put it more open because we settled it in court. Some time ago, pre-COVID, Barbara, one of my past presidents spoke, of course, for RNAO in the media. That's their role. And actually, that person was fired from her organization, okay? And we actually took a legal case. It ended up resolved. She was compensated. RNAO was compensated. But it's a very serious issue. Organizations believe that they have a right to tell nurses, no, you cannot speak with the media. In our view of RNAO, it's detrimental to the organization that does it because it shows lack of trust and transparency of what nurses or others will say. It also appears to be as if you have something to hide when that may not be the case. It might be that that nurse wants to celebrate how well prepared they are. So it's a very important question, and it is an ongoing, not only during COVID, Barbara, an ongoing stumbling block that my communication team and myself experience daily. You have no idea how many media have said, can you give us a frontline nurse to speak about that? And then when we go to the person and the person says, oh, I would love to. And the person, we say, you know, you need to make sure if you're speaking as, you know, with anonymous, or if not, if they will see you, you need to go through your workplace, and many times they're said no. So that's a big problem, and I believe, Barbara, likely that's a problem globally. And you know, there have been situations that I see, both I have seen tweets from important groups, whether it's ICN, whether it's STTI, and yes, I am wearing my STTI, Virginia Anderson pin, or whether it's by others, that we kind of say, well, you know, the media needs to pay more attention to us. We are not enough in the media, et cetera, et cetera. Colleagues, it starts with us. It starts, first of all, with professional associations and unions, and all of the associations of nursing in between, speaking out as much as possible. And then it continues with pushing our own employers of nurses to say yes to nurses. You can speak because you have important things to say. You are doing, in COVID, heroic work. Yes, if you don't have PPE, speak about that so we can get more PPE. Just imagine the force of nursing if employers will start to say yes. So it's an ongoing issue. And I would say, let's not shoot nursing when we do these tweets about we are not being heard. The media very much wants to hear from frontline nurses. Let's power them, not empower them. Let's power them to speak with the media, because we will change the world, colleagues. If frontline nurses could speak freely to the media, we would change the world for the better during COVID, pre-COVID, and after COVID. So if one learning we can take, Barbara, from that maybe we can take collectively, is power nurses to speak out and don't punish them when they do.
Thank you, Doris. There's I just want to tell the participants, we've got 2 or 3 other questions sort of coming in as a kind of follow-up to that. So we will get to them. I'm going to give Doris and her team a chance to finish the presentation, and then we will get to these questions. It's not that I'm ignoring you. I see them.
Thank you. Thank you for posing the questions. Those are critical questions that allow us to dive deeper into what are the really barriers that are put against the profession, that the profession needs to turn out, not in saying we are not being heard. Was a tweet in the weekend about we are not being in policy tables. Well, in Ontario, we are. So if we are not in policy tables, we need to push ourselves in policy tables. We are not in the media. Yes, we are in Ontario, but I want more and more, and my colleagues want more and more as frontline nurses in the front lines of street health, of home care, of nursing homes, of hospital care, to be our front page to the media, because we will change the world. So that we need to push up, not push down, in terms of how to get there. Laser focus on vulnerable populations is what I think nurses all over the world do, Barbara. If you think pre-COVID, not yet, please, Susan. If you think pre-COVID, think about Ebola. Who was in the front lines of care? Nurses. If you think about malaria, who is the front lines of care? Nurses, support workers, community workers, right? If you think about birth delivery in many countries, who are in the front lines? Midwives. And this is not only in less well-to-do countries or low-resource countries. This is, take Chile. 80% of the deliveries in Chile are done by midwives. So when nurses are at the front lines of speaking out, speaking with, and speaking for, depending what's needed at what time, for vulnerable populations, all of the populations, everywhere in the world. This is not particular to RNAO. We just are taking it with a laser focus as we speak now during COVID-19, because vulnerable populations here in Ontario, and from what I see around the world, also the UK, what I see around the world, Italy, where deaths of people were only counted if they happen in a hospital. That tells you the story. And I have spoken with my colleagues in Italy, devastated by that. Or if you see it in many countries, right? Vulnerable populations as a whole have been let down. RNAO is not willing to stay quiet about that. As I said, I know the command center is yet again discussing about that today. We need the data about vulnerable populations. We need the data about segmented by those vulnerable populations that are in confined settings. We need social determinants of health data that is in some places not even being collected. What gender has to do with COVID, what are, at least on the death rate of people, is a story behind every case, right? So what is their gender? What's their race? What's their economic status? Do vulnerable populations are more hard hit? Absolutely yes, and we will speak a bit about that, because we believe on health for all, same as Dr. Tedros believes on health for all, and same as Nursing Now, ICN, and all the large nursing organizations, STTI and others. And of course, we too believe on health for all, and so does every nurse that I know in the world. Next one, please, Susan. So protecting long-term care clients or residents. This is data that relates to long-term care and retirement homes in Ontario as of April 13. This is data just from some of it. We have had all in all about 130 outbreaks of COVID-19 in nursing homes and close to 70 in retirement homes. So you're talking over 200 homes have been hit hard. 50% of the overall deaths in Ontario are deaths that have happened in long-term care as of today. That is unimaginable. That I have no other word to say, that is an utter and devastating abandonment of people in nursing homes. And I say it with sadness, I say it with tragedy, because these are the people that we said to their families, we will not allow you to come any longer to the nursing home because we want to protect your loved ones. And I say to them today, we didn't do well enough to protect them at all. And so many lives have been lost already, and those families will never be able to embrace them again. We want to make sure, and we have been speaking about this from the beginning, Barbara, and we are saying we cannot buy time back, but every day that is left, let's do much better so families actually can go back and embrace their loved ones once again. Next one, please, Susan. Protecting people that live in shelters, persons experiencing homelessness, and in correctional facilities. Those are settings where people are absolutely living in crowded situations. I want to differentiate between residents living in nursing homes, persons living in correctional facilities, and persons experiencing homelessness and living in shelters, because there is a major difference from a public health perspective. Residents that live in nursing homes are confined, and the spread occurs mainly inside that confinement of the nursing home, and that's why we see what we see. The only ones that come and go are the health professionals that likely inadvertently brought COVID-19 to that nursing home, unless was a transfer from a hospital, and that has happened too, and those have been stopped since 2 days ago. The situation in correctional facilities is similar. People that are confined, they're not out and about, so either it's a worker that brought it to the correctional facility, or is a new inmate that came to the correctional facility. The spread happens within the containment for the most of that facility, and fires have been going big time in the US in correctional facilities with devastating effects, and in some facilities in Canada, not as much yet in Ontario. However, is a fire waiting to happen. Shelters is different. People that experience homelessness live in the shelter at night for the most. During the day, they are not for the most in the shelter, then they're out and about. Which means not only this is a threat of COVID-19 to the people living at night in the shelter and to the staff that works with them, it is also a major threat. Threat for communities at large. And unless we will start to do much, much more significant universal testing, and I say this without an error, universal testing, in all the correctional, in all the shelters, we will continue to have a second, third, fourth wave because we are not suffocating COVID-19 in any way or shape, right? It's like in a home, and this goes for all these settings, whether it is correctional facilities, shelters, or nursing homes, and in fact also our indigenous communities, which I will speak in a minute. It's like in a home not having the fire alarm, right? And all of a sudden you see the house in fire and you call the firefighters. That's exactly what we are doing, colleagues, because the fire alarm for COVID is actually surveillance testing. And if we don't do surveillance testing, let's not be surprised that we then need to rush with the firefighters, which are the nurses from everywhere, PSWs from everywhere, infection control from everywhere, and rush PPE because we didn't rush it ahead of the fire being gone. Let's not be surprised. It's a policy-driven fire, and we got to stop it because these are our most vulnerable populations. People that live in shelters are so many more times at risk because of their condition, not only the crowdiness that they live, but their social determinants of health conditions. So much more at risk of contracting COVID-19. People that live in nursing homes because of their vulnerability and the multiple comorbidities. And people that live, next slide please, in indigenous communities, so much more at risk, again, because they have the two double whammy factors. They live, many of them, in utter poverty. It is, I say, always the most shameful mark of Canada as a whole. The fact that ongoingly, not during only COVID-19, we are not doing enough in my country, in my own country, to protect indigenous communities. We are not doing enough at all in giving them the tools and the resources for self-determination. And we believe they would do a lot better if we did. If we give them the resources that belong to them, because this is their country, to tell you as it is. This is not ours, we borrowed it. So we need to give, at the very least, the resources needed, to give the tools needed, and to let them do what they know best how to do, which is take care of their own. And we should be there, as RNAO is now there, and Sabrina Miraldi with Grace Suba are the lead people for us there, Matt Calway and others, helping us to really enable, facilitate, support indigenous communities to do what they know best to do and protect their people. Their issues are different than ours. The issues of not wanting to be tested because of taboo on the testing. By working with Chief Archibald of the First Nations community, Barbara, I have learned, and I'm learning every day by working with her and her team of experts, so very much. All we need is to really open doors where doors need to be open, and support where support is being asked, and then give them the tools and the resources. They will do it much better than us. So that's for sure. Next one, please, Susan. Intersectoral and interprofessional collaboration has been huge during COVID-19. One of the tremendous partnerships that we have is with Inner City Health Associates, where we supported them in their vision of Dr. Andrew Bond and our colleague, Dr. Lee Chapman, a stellar nurse that sadly 5 years ago lost her own brother that was at the time homeless to overdose. Inner City Health Associates is at the forefront of always taking care of persons that experience homelessness, and they, together with Doctors Without Frontiers, actually opened already 2 sites supported by the City of Toronto, Mayor John Tory, thank you again to you, and by our Minister of Health, Christine Elliott, and by our Premier Ford, who understood the importance of their work and working with their partners of Inner City Health Associates and Medicine Without Frontiers. which I must say, Barbara, with all due respect to Doctors Without Frontiers, the majority of workers are nurses. I do need to say that. Someday should be changed about Doctors and Nurses Without Frontiers, but nonetheless, huge respect for Doctors Without Frontiers that are bringing their expertise for large scaling of this model. I believe that as much as the tragic situation of COVID-19 in nursing homes will be the worst chapter in the history of COVID-19 in Ontario and perhaps in the world. The care of people that are COVID, either expecting the results of the test or COVID positive in Toronto, thanks to the ICHA partnership with Doctors Without Borders, will be perhaps the most beautiful chapter, because these individuals will be saved, many of them, I believe, and will continue to live on and to be part of our community. And also those that will not get the chance to live will actually have the dignity of care that they need and deserve. So kudos to Lee Chapman, who is running a nurse-led model with 100 nurses that have been hired through Via Nurse, and I know that we will be speaking about that later on a bit more through Via Nurse. And then partnerships that we have had with the Ontario Medical Association in putting press releases out together, with the College of Nurses in terms of linking Via Nurse, and also the issues of not moving students completely out, but facilitating those that need to graduate to actually be back on the front lines of care. A special partnership with Advantage Age Ontario, my colleague Lisa Levin, who was in the past the director of our health and policy department at RNAO, and now is a tremendous CEO of Advantage Age Ontario, the not-for-profit association for nursing homes. Tremendous partnership with them, and I know that Heather will speak about that, and with the pharmacies when President Trump, who never ceased to amaze me, I must say, always there is a new surprise, when he said that one of the medications that is used for arthritis and for other conditions was good for COVID-19. And what was detrimental about that is that it had not been tested even, right? So that's number one, which is detrimental. What was even more detrimental is that the remarks of leaders have impact. And the impact here was that the next day there was a shortage already of that medication. So we did a press release with Ontario Pharmacists Association and OMA and RNAO to alert doctors and nurse practitioners to please do not prescribe that, because in Ontario, thankfully, those are by prescription. So tremendous partnerships with everyone. I know that Susan McNeill will speak about our OHT, so I will not spend time on that, but tremendous partnership with them as well. Also, and many others, nursing schools, etc., many others that we don't have the time to mention or put in the slide. Next one, please. And with that, I just want to share that we have used social media constantly. Thank you, Madison from our team, who is the social media guru, and tremendous activity in the social media. It is an important platform, colleagues, for all of us to use. It's crucial because social media is like a microphone to the messages you have. And you all have important messages. So please use that microphone, the more the better. I did put at the center there Dr. Tedros, because I do want to make a special mention on the elegance, number one, the maturity, number two, and the intelligence, number three, to respond with very, very strong and yet concise messages. And this is my own interpretation. So Dr. Tedros, I'm not saying this is what you did because you did it for this purpose. This is my own interpretation as CEO of RNAO. When President Trump decided to hold the funding for WHO, as a nurse, It is a must for all of us colleagues to speak. When any funding from any of our countries is being put on hold for WHO, it's not Dr. Tedros or his team that is being impacted. It's the less well-to-do countries. It's the less have-to-do countries. Countries like Canada and the US, trust me, will not be hugely affected because we have the means to do what we need to do. But many, many, many countries depend on WHO for directives, for support, for everything that they're doing. And this is not only related to COVID-19. WHO is tackling many, many, hundreds of more situations, including epidemics in many of the less well-to-do countries, Ebola being only one of them that we saw as of late more success. And the more success is because of two things, WHO and the boots in the ground by the people that work there. So we absolutely must react. We must react. I did put it on my blog. We need to absolutely join initiatives like the Avast that put pressure on President Trump. We need to support the response of WHO. And I want to go back to the elegant way that Dr. Tedros, who has become one of my heroes since I met him at the CNA meeting in ICN, at the last ICN meeting, and he came and surprised all of us. Not only the elegance and way of speaking that day, but the responses that he has done. You must follow Dr. Tedros and you will see. He started by saying, courage. That's all I said, courage. The next day, he said another critical word. And yesterday, he said forgiveness. And colleagues, it gives me the shivers because you need to be big. You need to be a giant to be able to not blast such an inhumane activity, such a inhumane power over that President Trump did. And with that, I want to mention one more person that you should follow, and is the chief editor of The Lancet. The chief editor of The Lancet called the act of President Trump a crime against humanity. And I tweeted and retweeted that as well, because we have a duty as nurses to call it the way it is and to uphold any funding, even a penny, at a time of COVID-19, when it's overlayered on poor countries, on less well-to-do countries, poor in terms of money, poor in terms of income, not poor in terms of people. They have one of the richest people in the world, because these are people that have the courage, the knowledge, and the stamina, and the conviction to take care of their own in the midst of no resources. And so to say that you will uphold a penny, let alone all the funding, it is a crime against humanity, and we as nurses need to call it the way it is. Let's move on to the next one, please, Susan. So RNAO solutions, next one, please. And I will, with that, let my colleague, Heather McConnell, Associate Director for Knowledge Translation at RNAO, and a queen of COVID in my view and in my book, because she has been central to our solutions and to the work we are doing specifically with long-term care, but not only with long-term care. Heather, all yours, please.
Much, Doris, and hello, everyone. My pleasure to be with you here today. We've been developing a large number of resources and supports, many of which I'm going to speak about today, and we've had a wealth of information on our website. And if you've been following Doris's daily updates, you'll know that we moved from an email that she was sending to her blog, an evolution of that in terms of being able to help support and find the information that's on our website. So as of last week, we had a meeting with our communications team and said, you know, we need to find a way of making the information easier to find. We have wealth of resources and people need an easier way to find them. So over the weekend, this amazing work was done to be able to actually establish a COVID-19 portal on our website. And certainly I'd encourage you to go to rnao.ca/COVID-19, where you'll find a multitude of resources, many of which I'm going to speak about shortly, that are available to you and your colleagues and others to support them in their work related to COVID-19. But some of these include Doris's daily blog, resources for long-term care, information about our workshops, etc., the virtual workshops, etc. So please visit that site, and you'll be able to find many, many resources available to support you with your work.
Only one comment before you move from that,
yep.
Susan, if you can go back. Go back to the slide, Susan. Any resources that you find here, you are allowed to use it. You don't need permission from us. You are allowed to use it. If you need some of those guidelines that Heather will share, or use it, right? Adapt it from, if you really adapted it, or adopted from, and reference RNAO simply because to be cautious about how it needs to go. But use it, you don't need our permission.
Great, thanks, Doris. Okay, next slide, Susan. Yeah. So the Via Nurse, and this is something that Doris mentioned previously in her discussions, and Via Nurse was established. I was just reflecting on this. It's been about 7 weeks ago now. And this was an approach that we took to help support the surge capacity for health human resources. And we've been able to recruit thousands of nurses and nursing students to meet health system needs. We actually launched Via Nurse on a Thursday evening about 8 o'clock. It actually went out in Doris's daily update, requesting volunteers to help provide virtual care, thinking we'd be able to help support contact tracing, etc. And overnight, we had hundreds and hundreds of nurses that signed up to provide virtual care, hundreds of nurses. That was the first day. And you'll see from this slide that since then, we've expanded that request for virtual care to include clinical services, critical care nurses, of 1,013 critical care nurses signed up to say that they were ready and able to help support should the need be there. 283 nurse practitioners have registered on our portal. Over 7,000 RNs and NPs for those virtual clinical care services, and 419 for seniors and residential care organizations have signed up on our registry to look for support for health human resources. So we've been able to support this surge capacity over the last 6 weeks as helping to support and plan for the needs of health human resources in these organizations. And we're delighted to be able to support. You'll see with this letter that we received from one of the very first individuals and organizations who reached out to access that virtual surge capacity was the Ottawa Public Health. And they were able to quickly enhance their capacity for triaging test results and case management and contact tracing by getting an additional 100 nurses in a very short period of time, within 72 hours actually, from RNAO. So we were able to utilize those nurses that had signed up for virtual care, and we were able to deploy those to help Ottawa Public Health with this work so that they've been able to provide 7 days a week services in these areas. Next slide, please. So in terms of Via Nurse for capacity for HR needs and shortfalls, this has been an important part for long-term care. And it was actually brought to our attention that nursing students could work as personal support workers or unregulated providers in long-term care facilities. And so we actually, again, utilize the supports of nursing students through that Via Nurse that I just spoke about to be able to help support long-term care homes and meeting the needs that they had for the provision of personal support worker type roles. So that's been an amazing opportunity for nursing students who have been in their nursing programs to be able to apply the knowledge and skills that they have and also contribute significantly to the care of residents in long-term care homes during this very, very difficult time. And what amazing leadership opportunities this has brought forward for them in terms of being able to understand from direct experience working in a pandemic situation and what needs to happen in terms of leadership in these organizations. We also have a group of nurse practitioners that work in long-term care, and they provide primary care services and other services to the residents that live in these homes. We also recognize that they have a lot of questions and need for support because of their unique role. And so starting about 3 weeks ago, we started twice a week meetings with the nurse practitioners in long-term care. These have become important forums for not only the nurse practitioners to have an opportunity to meet and discuss clinical issues with each other, but also an important forum for us to gain knowledge and understanding of what the frontline experiences are about, that nurse practitioners are experiencing, identifying policy issues that we need to take focus on in dealing with the government, but also being able to help support resource development for them. And so one of the first things that came forward was a need for a protocol on isolating residents very early on in this work. And we identified the need to not only understand, being able to isolate residents. And what I mean by this is not only personal distancing, physical distancing within a long-term care home, but also being able to be creative in how do we separate those clients that are residents that are COVID positive from those that aren't, or that are pending test results. And so our long-term care best practices team, we have a team of 14 registered nurses who work in long-term care across the province of Ontario to support the uptake of evidence-based practice, RNAO's evidence-based practice guidelines in those long-term care homes. We were able to utilize their expertise to help develop a number of different protocols. And the first one was isolating residents, as I mentioned. And we did that work in conjunction with Advantage Ontario and the Ontario Medical Association. So we developed the tools and we got their endorsement and were able to release that a number of weeks ago. And again, that is on one of our portal sites. Other resources that we've been able to develop that came through from this nurse practitioner long-term care group include resources to support end-of-life care during a pandemic, and also mental health and well-being resources. How do we care for their patients, their relatives, family members, and ourselves? Susan, do you want to move to the next slide?
Heather?
Yes.
There was a question where to find the resources. The portal is, so you can, the colleague that asked about where to find the resources is all on the portal. So the first section on the portal is resources, that's where you go.
Yeah. Thank you, Doris. We also developed, from this NP group, and recognizing a need with Advantage Ontario, an opportunity to provide supports for family members with relatives living in long-term care homes. And so we started about 3 weeks ago a Facebook group called Supporting Connecting Families. We now have over 170 members in this group, and this is this group is moderated by members of our long-term care best practices team, registered nurses who have expertise in long-term care. And the purpose of this forum is really to share stories and get support from others experiencing the impact of social distancing and not being able to be with their loved ones in their long-term care homes. And the types of questions and discussions that have been going on most recently have been about virtual visiting. How do we make that happen? How do we stay connected with our family members? There's been some need to interpret or provide direction to new directives coming from the government, et cetera, et cetera. So these have been a really important forums for those individuals that have loved ones in long-term care to have an opportunity to talk to others with similar experiences. We subsequently to that launched 2 additional Facebook groups, probably about 2 weeks ago now, just after the holiday weekend. And one focusing on sharing and tackling emerging care issues together. And again, this rose from our NP group. Things that they were thinking about, needing more information on, but really being able to help provide mutual support related to practices that promote safe, high quality care. And in that group, we currently have over almost 100 members. And the types of things that they've been asking about are nursing care planning for COVID positive individuals with mild symptoms, legal issues, networking related to team structures and acute care, et cetera. So really looking to each other to get some ideas about how can we move forward and be providing safe, appropriate care. And then to help support nurses and other health professionals who are dealing with COVID, a peer-to-peer support group. And again, this is not all of these groups are moderated by members of our International Affairs and Best Practice Guidelines program team, and our policy team, our clinical and policy teams, to be able to help support and ensure that the resources and tools are evidence-based that are being shared. So peer-to-peer support obviously is for sharing experience.
Quick technical question. Are the Facebook groups open or closed?
They're closed. You need to be invited to join, so you can go to the site and click on join, and then you'll be accepted as a member. Okay, Susan, do you want to go to the next slide, please?
Can you see?
Actually, just before I move, because this is Susan's slide, I do just want to say that if you go to the RNAO Facebook page and click on more, you'll see that there's 3 groups there. The RNAO long-term care support is intended for families. So it's really not appropriate for the people that are on this call, but the other 2 are very much available. You'll have to answer a couple of questions, and once we've got your name, we'll be able to accept you as a member. Okay, so I'm going to turn things over to Susan now. Thank you.
Great, thank you. Hello, everyone. So I'd like to tell you a bit about our Together We Can Do It campaign that actually includes multiple initiatives, and I'll focus in on the Chair for Health Workers. So this started March 19th, and RNAO challenged all of the people of the province of Ontario at 7:30 every single night to open their window or step outside onto their balcony or their doorstep and cheer for health workers. And so we asked them to make noise and show their support and their gratitude for the millions of health providers, the social service, and other essential frontline workers, not just in Ontario, but really throughout Canada and around the world. And the response has really been incredible. So I've got a snapshot of some of the variety of awesome things that we've seen. So people are banging pots and pans, lots of art, lots of kids art. You might have seen rainbows as well in your community. That seems to be what kids are doing. And signage. There are neighborhood bands popping up all over the place, keeping some social distance, but playing in their neighborhoods. Costumes. I heard on the radio last night that there are unicorns in addition to this dinosaur, all kinds of creative and fun things that are happening. I'll show you another slide here. Virtual meetings, people are cheering every Monday night. If you join us next Monday, we have a webinar every Monday evening, and at 7:30, our virtual meeting, we get out our pots and pans and our noisemakers, and we do a virtual cheer. There's been all kinds of musicians from balconies, the high rises, they're making lots of roaring noise and applause, which is so wonderful. Lights on police cars, and all kinds of creative ways. So what we're doing is we're encouraging people to post their cheering up activity on social media, and using tagging RNAO, and using the Together We Can Do It hashtag here. And in a later slide, I'll show you the Cheer for Health Workers as well. And it's just so inspiring to see how this has taken off. It's getting louder and stronger every night, really across our country and even to the UK. And we've joined in this sort of global chorus of support. It's spreading hope to people working on the front lines. It's giving us strength. It's raising our spirits each night. And I've heard from a lot of people that it's helping us feel more connected to our communities and our neighbors. And so Doris has mentioned Dr. Tedros, and he said, he was talking about this cheering that's been happening around the globe. And he said, the amazing spirit of human solidarity must become even more infectious than the virus itself. And I really do think that that's what's happening. So we're challenging you, if you aren't already doing this, and I'd be curious to see maybe in the chat box if people are doing this, or if you have any comments about this. If you're not doing it already, to join in this community building moment, this across the world moment, really, and do this every evening until we beat COVID-19, and to be active in sharing what you're doing on social media and using our hashtags I'll share a little bit later. So I'm just going to show you an example of what was on Blog TO, And this is one neighborhood singing and performing.
So everybody in Canada knows somebody that has a family member who's working in the hospitals right now as a nurse or an administrator or a doctor, and it affects everybody. It's 6 degrees of separation. You're gonna know somebody that's doing something really important right now, and that's just important that we came together as a neighborhood and to recognize all that great things that they do for us that we don't see.
I love it. I just love it. I just love it. And I need to give kudos with that to Barbara, because Barbara, I keep saying, Barbara must have taken it to the UK because she retweets some of our things. And I know that now we have a lot of those tweets from different chief nurses and other people in workplaces in the UK. And I just get so tickle pink. It's just so nice to see that really has taken over to so many places. It's beautiful. So all of you can use it.
Fantastic. And actually, we just had a message in the chat box to say rural Ontario town rings steeple bells each evening at 7. Isn't that lovely?
Fantastic.
Yeah.
So, Barbara, I don't know if there are other questions that we can answer. I would like to hear also from people. So let me just say ways that people can keep connected with us. First of all, the blog. Any of you that wants to access the blog, first of all, is open to the public in the website under blog. But if you want to receive it every night at whatever time that we send it, I finish usually writing at 1 a.m. so you will get it. But then send us an email and we will put you in the distribution list. Otherwise, it is in the portal of RNAO. Recent topics have been PPE, the tremendous work in Balearic Islands. By the way, in the Islas Baleares, the Minister of Health, Patricia Gomez, with whom I have become a friend way pre-COVID on evidence-based practice. She actually is a nurse, re-elected and reposted as Minister of Health, so 5 years as Minister of Health. They are doing remarkable work. Their entire approach was primary care and home care. So that is in the blog for those of you that want to see it. As we said before, we will have on April 30th, I believe at 3 p.m. Toronto time or Canada, well, Toronto time, and which is 9 p.m. Spain time. And Adelaide confirmed already, by the way, Barbara, so that's fantastic, and so did others. So we will have, and you will likely hear from Patricia herself or with her second in command, Carlos Vilafia. They're amazing people with a fantastic team. Other topics are, of course, the issue of the World Health Organization, epidemiology. What you will see in the blog is bigger letters and smaller letters. That's not something that we make up. That is called tagging, and topics that we have discussed more become larger letters. So it will allow you to see topics that we have discussed more also. So.
Thank you. Thank you all so much. What a rich webinar. I mean, packed full of information. We do have some questions. So the first group I'm going to take is about what you were talking about much earlier on, about following the recommendations, you know, for example, one of the examples that was given, advising health workers to wear one pair of gloves or one mask for an entire floor of residents. So this nurse wants to know, what can she do? You know, how can she speak up? In fact, she said, this nurse said, she's been fired because she did speak up. So she wants to know, how can she be an active advocate for nursing right now? And I'm sure she's not the only person.
Yeah, no, Barbara. And the thing is this, and I'm glad that she has the courage to say she was fired. First of all, if she's from Ontario, to please call us. We are currently have put a lawyer on another colleague that actually, Barbara, she refused basically to put a patient that came from the hospital COVID positive in the same room as other residents that were not at all with even symptoms. And she was not fired, she was asked to resign. In any case, we are actually dealing with that too. So my number one answer is thank you for speaking out. My number one answer is always thank you for doing what's right. And then, yes, when we do that, sometimes, including one of my past presidents that I mentioned, there are consequences. What I can advise, though, that in the future, before you take those actions, and I said the same to the colleague that is now with the legal counsel, please speak with us before, because sometimes we can speak for you, meaning you will not be fired, right? So it is a very challenging situation, Barbara, and we have seen it happening pre-COVID on other things, and we see it during COVID, and we will see it after COVID, and it's the issue of the relationship of nurses as employees, and the fact that employers, and I would say it's not all, there are fantastic employers, so let me also be fair with that. Many, the vast majority of employers are absolutely fine people and very fine nurse leaders. And then you do have bad apples like we have in any profession. And that goes for staff nurses as well as for managers or executives for that matter. And it reminds me another situation where a nurse also questioned the issue about N95 and not having enough in a specific organization. And I did put it on my blog, by the way, without the name of the nurse. And the manager in the unit said to her, well, you knew you signed up for it. And the nurse said, no, I didn't. I thought that I signed up for taking outstanding care of patients. I didn't know I did sign up for working without N95. And the manager said, or at least that's what was reported to me, well, yes, you sign up for that too. I wouldn't call those type of answers leadership, Barbara, first of all. True leaders are genuine in feeling the pain of the other. If that other is a staff nurse that is a leader at the bedside or street side and feels the pain of the patient, or if that is a manager that feels the pain of her or his staff, or if that's an executive leader that feels the pain and pushes up where the push needs to happen rather than pushing down. Those to me are the true leaders in any role, from staff nurse to executives. So I am very sorry that is your situation. If you are in Ontario, please connect with us and we will see how best to support you on that.
Good.
And if you are in another country, I suggest you contact your professional organization.
Yes.
Many times they can give you voice before you risk your own job.
Yes, I agree. I think professional associations are coming into their own here at the moment, and certainly in the UK, our own Royal College of Nursing has advised nurses that if they don't have protective equipment, they have a right to say we are not going to work here at doing this. So another one of our attendees has said, you may have heard of this, I hadn't, but it's a video platform called NurseUps, nurse and then UPS, all one word. And they say they're encouraging nurses to speak about their experiences because they want to speak, but they're afraid of losing their jobs. And I think we've just been talking about that. it's very important to find a voice and to speak up. We had another question associated with
I
that,
love
which
that
is,
if you can, if Hannah, if you, or PG, if you can take that website
yes.
or that app. I didn't know of it, so thank you for sharing.
Yes, I was just actually saying to somebody else who'd written about a website that if people who have these sites and information, if they let Nursing Now know, and you, I'm sure, Doris, we will amplify those messages. We will
100%.
get them out there. Yeah.
100%.
So there's a question about, would a written letter from a nurse manager be okay to give a nurse, as it were, permission to speak to the media? What's your view about that? Sorry,
can you repeat the question?
If a written letter from a manager would be okay, I guess they're talking legally, as permission to speak to the media.
Absolutely yes, absolutely yes. Even an email. If the manager tells you on an email you can speak, that is good enough. Let's not complicate the life of managers by big, legal things. If the manager sends you an email, yes, you can speak, you can speak.
Okay, great.
That should be sufficient legally for you.
We also had a question from somebody who described themselves as a member of the media. They had a follow-up question about retirement homes. They were talking about a union rep who worked for a retirement home who said that the directive that protects the jobs of those who choose to work in one long-term care facility doesn't apply to retirement homes. So that was, we had that conversation, didn't we? You believe, this person asked if there can be some clarification. Yeah, I believe you said it does.
It does, but it does. Let me clarify, which is also peculiar. It does not affect nurses in hospitals. Get that one. So here is the difference between what's best practice in policy and what happens in practice on directives. I'm not just saying interpretation, directives from government. And we had this discussion this morning with government. So the one employment, yes, applies for nursing homes and retirement homes. However, they're sending now nurses and doctors too from hospitals to nursing homes to give some support on infection control, and then back to the hospital, and then back to the nursing home, which makes no sense to me. But they are doing it to facilitate the support they need. Well, as Heather mentioned, we have 7,000 nurses. We have close to 300 nurse practitioners. We have plenty of people that can work in one place. Let's not move people back and forth simply because it's convenient.
Okay. So I heard from the person who has who wrote earlier about I think it was Nurse Ups he wrote about, and who says, I'm the president and founder of African Nurses and Midwives Network. We'll be happy to work with RNAO in development of resources to support nurses during this COVID-19 and in the future. They're currently in about 20 countries. So that's wonderful. That is ready. Exactly why we do these webinars.
And we are ready. Yeah. And also, Barbara, to the colleague that just wrote, also we can engage you in the evidence-based practice program. So beyond, let's think about life beyond COVID too.
Yes, I think so. And somebody sent an interesting question that I've never thought about, but you might know. Are there any dogs being used to support communities, e.g. taking food to housebound people? I don't know.
Well, first of all, we don't know enough about the situation with pets now, right? So we don't use pets for anything now. I can tell you that my husband and I have not hugged our grandkids or kids or Jack the dog for all this period because there is not enough clarity about pets. So I don't know the answer. I don't know the answer, but I could find the answer for it. I could try to find it.
So if the person who asked that question, if you put the question, could you put it on the portal, your portal?
Yes, we could.
Okay, that'd be good.
We could, but I think where I will check for the answer, again, because I have checked before, is actually with the public health officials, with the medical officer of health. Because, you know, at the end of the day, they are the ones that give those directives.
Yes. There's a question here, very, it speaks to, I think, the whole idea, in fact, there's a couple of questions that speak to this idea of building back better. So what can we learn from what we've done so that if this happens again, and I'm sorry to say it probably will in a different form, but what can we learn? And this one I think is very interesting. It's asking about frontline workers having a poor wage, you know, lack of a living wage, no paid sick days. And those are the structural reasons why they have to work in more than one facility. And talking about privatization and for-profit models of care. And what can governments do? And that speaks to me of investing in nursing, since we're talking about nursing.
Yeah,
I'd like to hear your comments.
Yeah, it is investing in nursing, and it is investing in vulnerable populations sectors also. It's both. Because at least in Canada, and I believe in most of the world, nurses in hospital care get paid better than nurses in community care. Get paid better than nurses in long-term care, get paid better than nurses that work in a shelter. So I think it's twofold. One is investing in all sectors, which in Ontario has been our mantra for the last 10 years related to nursing homes and related to other vulnerable populations that we mentioned. And second is investing more on nurses. And one colleague of the many hundreds of emails that we have received nailed it probably best to me on how we will pursue going forward policy changes related to nursing. So we have been on the policy arena pursuing equal pay for nurse practitioners across all sectors, because in primary care they used to be paid less than in hospital. I think we need, and we were very successful, we need to do exactly the same for RNs, for RPNs, whatever is the category of nursing we have, for PSWs also, because they support our work, for midwives across the continuum of care, Barbara. So not because making a differentiated pay that if you work in nursing home, you get paid less than in hospital, already puts nursing homes and their residents and their staff in a terrible situation. So absolutely, yes. The second piece is the issue of full-time work with benefits across all sectors, because it is a public health hazard in all times. It's not only a burden on the worker, whether it's a nurse or a PSW, it's a burden on the clients. Best case scenario, no continuity of care and caregiver. Worst case scenario, you take an epidemic, let alone a pandemic, from one place to another. So absolutely yes. Now, will governments learn? Listen, we have been talking about, you can look at our reports, we have been talking about long-term care and the detrimental conditions of workers and therefore their residents for 10 years, okay? And maybe now on the debacle of what happened in Ontario in nursing homes, we will see finally changes.
Yes, thank you, Doris. It's 5:28, we've got 2 minutes left, and we've almost answered all the questions, I think.
Then we need to promote everybody to the panel so we can do a global picture and put it on the website of Nursing Now.
That's a great idea. And can we just also say there will be a recording of this available? It's certainly be on the Nursing Now website and on yours too. Yeah?
Yes, it will. And also on April 30th at 3 p.m. Toronto time, 9 p.m. and I'm saying 9 and not UK because of the Spanish, 9 p.m. Spain, and anywhere in between people will need to figure out. There will be in Spanish.
Great.
With Adela, who is in the board of Nursing Now, with Maite Moreno, my colleague from Spain, with Patricia Gomez, the Minister of Spain, Baleares, and people from Chile and other places. So join us and you will hear a Spanish version of different countries and what they're doing.
Oh, muchas
Fabulous.
gracias.
Thank you so much, Doris. Thank you, the whole
Gracias,
team.
Doris.
Can you put your microphones on? Somebody put the
Yes.
mics on, we can hear you.
Sí.
And your videos.
¿Dónde es la
Microphone,
micrófono?
videos. Alicia Torres, Spanish, ¿de dónde?
Susan,
¿De
we need
dónde?
Somebody's asking about
I can
Yo
contacting
hablo
Doris.
español, Mary.
Conéctate conmigo.
Gracias.
¿Estamos?
So you can contact Doris through our, somebody's asking about contacting you, Doris, through
So you can contact me
site.
at Doris at D Grinspun, PG, maybe you can write there at D Grinspun, RNAO.ca. Make sure to copy PG. And then you can follow me on Twitter at Doris Grinspun. I think that's it.
Okay.
Grinspun.
Madison, I don't know if anything.
Sorry. And you can contact
No, it's
Nursing
okay.
Now through our website. We
Fabulous.
hope to hear
Of course,
from
follow
you.
RNAO and Nursing Now.
And meanwhile, let's make a noise for health workers around the world.
And Barbara, you will say a message.
Somebody took that.
To make the noise for healthcare
We
workers
need
around
the
the world.
faces. We need the faces.
Muchas
The
gracias.
faces and the
I
mic.
can hear you.
All the nurses around the world. Barbara, give a message to all the nurses around the world, from Nursing Now, from RNAO, and from everybody that participated in today's webinar. Thank you for your work. Thank you for your work.
Thank you.
Muchas
Thank you.
gracias.
Un placer grande.
Thank you very, very much.
Hasta luego.
A
Thank you.
pleasure.
Bye-bye.
Thank
Muchas
you.
gracias. Chao.
Un placer, gracias.
Ciao, Bella.
Chao, Bella.
Arrivederci.
Arrivederci.
Auf Wiedersehen.
Wiedersehen too.
Wiedersehen.
And salam.
Yeah.
Don't we have salam and shalom?
Salam, shalom, om shanti.
Shalom.
Om shanti.
Om Shanti. Beautiful.
Sí.
Thank you very much from Toronto.
And I see Arlene from
Sí,
Qatar.
humba kukanyeni kwinkos.
Arlene Macaba.
Hello from
Hi,
Qatar.
Arlene. Good to
Hi,
see you.
Doris.
Keep well.
Corsita. Hi, Corsita.
Hey,
Au revoir.
au revoir.
Hi, Ottawa. How is Ottawa doing? You guys are doing good, actually. You have a fantastic public health team. Both our nurse colleague, Esther Mogadan, and the chief medical officer. Good for you guys. And of course, Deborah and everybody else in between. And our Pearly Rido, BPSO. My gosh, so many good people in Ottawa.
Oh,
Hi, Arlene.
wonderful.
That's nice to see you.
Oh, beautiful.
Alicia Torres, ¿dónde estás tú?
Doris,
Sí,
¿me oyes?
sí te oigo.
Oh, participantes.
Es que tenía un problema con el micrófono.
Oh,
¿Me oyes
sí,
ahora?
No me digas,
Aquí.
¿dónde estás? ¿Dónde estás?
Estoy en Valencia, al norte de Valencia.
Valencia. Qué rico.
Oh,
Arroz a la valenciana.
It's now 12:33. We'll have to say goodbye.
Bye.
Oh.
Thank you, guys.
au revoir.
So good to see you. we will have RNAO Nursing Week events. We should let people know they can check our website.
Okay. Thanks.
Haba bahaba.
Haba bahaba.